everybody, this is another interesting video of liver cirrhosis. So in this liver cirrhosis, I will be breaking the topic with easy mnemonics, crisp logic and scoring methods that you can directly use it in your theory exams. Moving on to the etiology, I have divided it into A, B, C, D, E, F and G. A is alcohol, which is the most common of all. Coming to B is biliary cirrhosis, which includes both primary and secondary. Third is hepatitis, includes Hep B and Hep C. And coming to drugs and toxins, you have methotrexate, INI-CET, and amiodarone. Moving on to the errors of metabolism, we have Wilson, alpha-1 antitrypsin deficiency, and hemochromatosis. And fatty liver disease, you all know about the NAFLD and NASH, or NASH. And the genetic causes and the autoimmune causes. So this is all you have to remember about the etiology. And the most common is alcohol. So A, B, C, D, E, F and G. Moving on to the pathology, there's inflammation, there's nodules and there's fibrosis. This is the triad that you have to remember for cirrhosis. So there's an inflammation. When it becomes chronic, it forms nodules, and when nodules become chronic, it fibroses, and finally you have the cirrhosis stage. So cirrhosis is irreversible end-stage liver disease with fibrosis and regenerative nodules. Moving on to the mechanism. First, what happens? There's a chronic injury, and then the stellate cells get activated, which further causes collagen laid down and the fibrous septa and regenerative nodules and disordered architecture, which finally causes portal hypertension along with failure. So this is the whole mechanism of action of cirrhosis of liver. And we know that there are 2 to 3 types of cirrhosis, which is micronodular cirrhosis, and then you have macronodular and mixed. And the most common for micronodular is alcohol, is A, and for macronodular it is viral, and the centimeters is less than 3 mm for micro and more than 3 mm of nodules for macro. So architecture distortion is also irreversible, which you have to remember. Moving on to the clinical features. So to remember the clinical features, I have given you the mnemonic which says liver fails. So what's happening in cirrhosis? The liver is failing. So it's the exact mnemonic I've given you. L for loss of appetite, I for icterus, V for varicose bleed, then portal hypertension, E for edema and ascites in the abdomen. And then you have right upper quadrant pain because that's where the liver is located. And then you have theta hepaticus, asterixis, increased bleeding, coagulopathy because you know all the coagulative proteins are present in the liver, and L for low albumin, which is called anasarca, and spider angiomas and palmite edema. So cirrhosis presents with features of portal hypertension and features of liver failure. Moving on to the investigations, we have blood test. Always we start with blood test, and 2 important things you have to remember always is LFT and CBC. In LFT, increased bilirubin, increased AST/ALT, increased ALP, decreased albumin, and increased prothrombin time and INR. Then you have the serum ascites albumin gradient and viral markers for hepatitis, autoimmune profile, and iron and copper studies. The second one is imaging. So you have an ultrasound that shows a shrunken liver with nodular surface and splenomegaly. Then fibroscan showing stiffness, CTR MRI with nodular contour and collaterals. Moving on to the endoscopy, we check for esophageal varices. It is to confirm if hypertension is there or not. That is the portal hypertension. And the gold standard, if needed, is what you have to do: biopsy. Liver biopsy is very important. So the investigations, putting them all together, it is basically LFT plus USG plus scope. So this is all you're doing during the investigation. Moving on to the complications, it is happy liver. So happy liver is the mnemonic I'm going to give you. And you can list the complications like this, which is H for hepatorenal syndrome, A for ascites, P for portal hypertension, P for hepatic encephalopathy, E for esophageal varices, E for edema, liver failure, I for infections, V for variceal hemorrhage, and E for endocrine changes, and and R for hepatocellular carcinoma. So it's important to understand that cirrhosis is the strongest risk factor for hepatocellular carcinoma. So it is the strongest risk factor. Moving on, we've entered the management. So management also, I've given you it in A, B, C, D, and E. So A is alcohol abstinence, because we know the most common cause is alcohol. So obviously you have to stop it and you have to address the cause. B is beta blocker, C is to control complications, D is dietary management, and E is end stage, where you have to plan transplantation. So individually, A, alcohol abstinence, and you have to address the cause. What cause are we addressing here? We are treating the hepatitis, and we are managing the NFALD, Wilson, and autoimmune hepatitis. Moving on to the beta blockers. Prophylaxis for varicose bleed, which is propranolol, which is a beta blocker. To control complications such as ascites, where you have to restrict salt, we give spironolactone along with furosemide, which are all diuretics. And then to control encephalopathy, we give lactulose and rifaximin. For varices, ban ligation. NSBP is ceftazidime. Moving on to the dietary management, this is basic, high calorie, moderate protein, and sodium restriction, and vitamin supplementation, of course. End stage option is transplantation. So I have an exam line for you where MELD score decides the transplant priority. So MELD score is what we use for deciding if the liver needs a transplantation or not. Yes, and that is all. This is the summary page where the causes is with A, B, C, D, E, F, and G. Clinical features, it is liver fails. Complication is happy liver. And management is A, B, C, D, E. Go back, take a relook, screenshot them, and study smarter. If this helped, hit a like and subscribe. See you in the next one. This is Amu from Med School signing off.